Here's a brief overview. Ensure that the basic ABCs of airway, breathing, and circulation are intact prior to any splinting activity. Expose any injured areas. Observe skin color and symmetry. Assess and document pulse, motor, and sensory function. Apply constant, gentle, inline manual stabilization. Of course, consider gentle long axis traction on severely deformed long bone fractures as per your local protocol. Return extremity to its normal anatomical position with an assistant supporting the extremity under the suspected fracture site. If the patient complains of increased pain or if there is resistance during manipulation, stop and immobilize as best as possible in the position found. Maintain manual support of the injured area while coordinating assistance during the FASPLINT immobilization process. Your healthcare partner or qualified assistant should apply appropriate dressings to all wounds in and around the suspected fracture site. Open the FASPLINT carry case and select a splint that will mobilize the area above and below the fracture site. Shoulder and hip injuries will require additional immobilization methods to accomplish this goal. The FASPLINT valve is a simple push-pull plunger type valve. When the valve is pushed in, the valve is closed. When the valve stem is pulled out, the valve is open. Open the red valve by pulling on the clear tube. Lay the splint out on the ground or on a flat surface and manually distribute the beads evenly throughout the splint. The FASPLINT should be soft enough to comfortably conform to the injured area, yet firm enough to keep the beads in place if positioned vertically. This adjustment method can easily be made by simply removing or allowing air to enter the splint. Here's a tip for connecting and disconnecting the compact metal pump to the FASPLINT. Insert the tapered tip of the pump hose firmly into the clear tube on the FASPLINT, but not so far as to make it difficult to remove. To disconnect the pump hose, hold the clear tube in one hand, and with your other hand use a braking motion to remove the tapered tip. This is similar to breaking a twig in your hands. It comes out easily. Your assistant should palpate distal pulses and check for capillary refill prior to application. Have the splint positioned for proper application and assist with supporting the injured area if necessary. Slide or place the splint under the injured area, positioning the splint so that at least one area to be secured is above the suspected fracture site and at least one area to be secured is below the suspected fracture site. Cradle the injured extremity with the splint and gently manipulate the beads into voids to provide the best conforming mold possible. The splint should conform easily. If not, simply adjust by allowing air into the splint. The splint edges should not overlap. Hold the splint in place, hands-on stable, by grasping both top leading edges above and below the fracture site. Tip: leave an open space approximately 1 inch whenever possible along the length of the splint. This provides proper mobilization, yet allows for visual inspection along the full length of the injured extremity. If the splint is too wide, fold the edge back on itself and smooth that edge to form a narrower splint. Be sure to palpate distal pulses and check for good capillary refill. Once the splint is properly applied, slowly release the support of the area, letting the splint cradle the site, assisted by your partner's hands-on stable support, which maintains the injured part in a desired and comfortable position. Open the FASPLINT valve by pulling on the clear tube. With the valve in the open position, connect your suction source to the FASPLINT. If you are using the Hartwell Medical compact pump, insert the tapered tip into the clear tube on the FASPLINT valve. Make sure you have a good connection and that the valve remains open as you suction. Evacuate the air from the FASPLINT until the splint forms a rigid cast around the injured area. You will feel resistance on the pump handle when the splint has been sufficiently evacuated. Once the desired firmness is achieved, close the valve. That is, push the valve stem in to close the valve. After the valve is closed, remove the tapered tip or suction source using the braking motion technique. Then recheck the FASPLINT for firmness. Now, the evacuated splint has formed a rigid supportive cast or mold around the injured area. Now, secure the splint in place. While maintaining support of the FASPLINT, recheck pulse, motor, and sensory function. Once confirmed, you may secure the FASPLINT with tape or other means. Continue to monitor pulse, motor, and sensory function en route to the medical facility. Of course, make adjustments if the patient condition changes. Adjustments can now easily be made en route, if necessary, to add stability or to make slight positional changes for patient comfort. All this by simply removing or adding air to the splint. Finish treatment of the patient with appropriate EMS equipment and supplies, based, of course, on the patient's needs. Here's another tip. During aeromedical transport, the vacuum splint may soften slightly with a significant increase in altitude. Adjust as necessary. The change in rigidity will not be nearly as noticeable as with the anti-shock garments, because of course there is very little air inside the FASPLINT once it has been evacuated. Removing the FASPLINT is easy. Number 1. First remove the fastening material, the tape, the cling, etc., prior to allowing air back into the FASPLINT. Please do not cut the FASPLINT. Then, open the valve and allow air to enter the FASPLINT. The FASPLINT can now be easily removed. Please make sure all hospital personnel are informed about these removal procedures. Please do not cut the FASPLINT.